therapy, monotherapy in patients who failed a non-steroidal aromatase inhibitor. During the administration of the treatment in general, the outcome is rather poor with standard endocrine therapy monotherapy. We can discuss, of course, the dose of fulvestrant used. Today, we use the 500 milligram, the new approved dose, because the confirmed trial has shown an improvement in progression-free survival when we give 500 compared to 250 milligram. But it is important to point out that the improvement is from 5.5 to 6.5 months. So indeed, if we do the trial again with 500 milligram, maybe that fulvestrant can be the winning, but based on indirect comparison, we don't expect that there will be a major benefit for the fulvestrant arm if this trial will be reorganized with 500 milligram. So what we need, we have to look to new treatment options for this patient, and we better understand today the resistance to endocrine therapy. And one of the problems is that the estrogen receptor can be activated in a non-ligand dependent fashion. We understand there's a crosstalk between the estrogen signal pathway and the PI3K-AKT pathway in particular. Indeed, it has been shown that mTOR can activate the estrogen receptor signaling in an estrogen-independent manner. On the other hand, if you block the PI3K-AKT-mTOR pathway, this induces apoptosis, and if you give now estradiol, this suppresses this effect. And in particular, the hyperactivation of the PI3K-AKT-mTOR pathway is observed in endocrine-resistant breast cancer cells. So this is really an excellent rationale to try to combine these standard endocrine therapies with a drug that target the PI3K-AKT-mTOR pathway, and in particular mTOR. Now we were of course all disappointed when a few years ago at San Antonio we have seen the first trial combining an mTOR inhibitor with letrozole. This was the Horizon trial. Nearly 1,000 patients were randomized to receive either letrozole and placebo or letrozole and temsirolimus. It has just been published. This was a negative trial. The question is, why is this a negative trial? Now there are several potential explanations. One explanation is that not all patients enrolled in this trial are really endocrine therapy resistant. Indeed, more than 50% of the patients had not previously received endocrine therapy, and this inclusion criteria is very different from the inclusion criteria in Bolero 2. Now, on the other hand, an alternative explanation that can at least also contribute is, of course, the schedule, because temsirolimus was administered during 5 days, and then the treatment was stopped for 9 days. So this was an intermittent administration, which give probably only a suboptimal inhibition of mTOR. Okay. So we were happy to see this phase 2 trial, which was a proof of concept trial, the TAMRAT trial. Here, the patient received either tamoxifen 20 milligram alone or tamoxifen with everolimus, and all these patients previously failed an aromatase inhibitor therapy. The primary endpoint was the clinical benefit rate at 6 months, and indeed, when you add everolimus, the clinical benefit increases from 42% to 61%. Is a 19% absolute improvement or a 45% relative improvement when you add everolimus. Concerning other endpoints, the median progression-free survival, you see it has been nearly doubled from 4.5 to 8.6 months if everolimus is added, and in particular the patient with a secondary resistance who previously first benefited from endocrine therapy have a major improvement from 5.5 to 14.8 months. And in this trial also the overall survival was increased but this is just a phase 2 trial, so it is important to have a confirmation, because the practice of oncology can only change based on phase 3 data, a registration, prospectively placebo-controlled trial, and this is of course the Bolero 3 trial. Here over 700 patients were included. All were refractory to non-steroidal aromatase inhibitor. They either progressed during the adjuvant treatment or the year following the adjuvant treatment, or during the treatment for metastatic disease, or the months following the end of treatment for metastatic disease. The primary endpoint in this trial was progression-free survival. Also very important to point out that this is really representative to the patients we see in the clinic. You see in this trial over 50% of the patients had visceral metastatic disease. And here are the results for the intention to treatment patient population. First, the primary endpoint based on local assessment. There is more than doubling of the median progression-free survival from 3.2 to 7.8 months. And when the central review of the responses was performed, then the improvement is even more important, from 4.1 to 11 months. Then an important question always is, do all the patients need this treatment? Of course, this is an expensive treatment. Sometimes there are significant toxicities. So can we identify patients that benefit more or less? So there are many subgroups prospectively defined, where the investigators look to the outcome, and whatever are the subgroups where you looked, according to the age, the region, the baseline's performance status, the progesterone receptor, the presence of visceral metastasis, bone-only disease, the number of organs involved, the prior use of chemotherapy, the prior use of other endocrine therapy, whatever you choose, in all the subgroups you have a very similar hazard ratio, so there's a similar magnitude of benefit in all these prospectively defined subgroups. This is further illustrated here. First, for patients with visceral metastasis, of course, in general, the prognosis is poor if the patient has a visceral disease, but you see a significant improvement here from 2.7 to 6.8 months in median progression-free survival. If you look to patients without visceral metastasis, again, and the same relative improvement, and here the median progression-free survival is nearly 10 months, and if you look to patients with bone-only disease, then the median progression-free survival is even more than 1 year. There is also a very important question: should we use this drug only late in the treatment, when the patient received many lines of treatment, or should we use it as soon as the patient failed the non-steroidal aromatase inhibitor? So one important subgroup is the group of patients who just received the non-steroidal aromatase inhibitor in the adjuvant setting and then was included in the trial. And what you see is that the absolute benefit in median progression-free survival is very important for this subgroup. The improvement is from 4 months to 11.5 months. So at least based on the Bolero 2 trial, there are absolutely no reason to postpone the introduction of this drug combination. As soon as the patient failed the non-steroidal aromatase inhibitor, the patient is an excellent candidate to benefit from this treatment. What about overall survival? This is, of course, always a very important question. We are still waiting for the mature data, and here it is indicated that we will see this end of 2013. In reality, we have to wait next year probably before we will see the mature data. What we can say only today is that each time when investigators looked to the overall survival, the absolute difference in the number of events increased and always favored the experimental arm, including everolimus. And you see at the last analysis, when the final PFS data were presented, the absolute difference is 6.8%. So we can hope indeed that when the data are mature, that we will see also an overall survival benefit. But today we are not allowed to say this. Now very rapidly, some aspects concerning toxicity. I will only rapidly discuss two important toxicity. One very frequently, stomatitis, and you see in the BOLERO-2 trial, 8% of the patients had grade 2 stomatitis. And then pneumonitis is less frequent, but sometimes this can be a severe side effects with 3% grade 3 toxicity in the BOLERO-2 trial. Now first, very importantly, if you look to the impact of the side effects on quality of life, it is really reassuring to see that the quality of life is at least as good in the patient who receive everolimus. Here you see the time needed for deterioration of the quality of life score, 5 points, and this time needed is even numerically longer in a combined treatment arm than in the patients who receive only exemestane. So we can conclude that the better disease control largely compensates the increase in the number of side effects. So concerning stomatitis, it is important to distinguish this from chemotherapy-induced stomatitis. These are mild mouth ulcerations. And what is useful to know is that in general this is very early seen in the patients. So if you don't see this mouth ulceration within the first months, then probably the patients will not develop this problem. And the other interesting thing is that over time, in general, the symptoms decrease. So you can try to go on with the treatment because probably over time the patients will better tolerate because the patients will have less side effects. So, for a practical point of view, we will of course give symptomatic treatments, different mouse bases with analgesics and corticosteroids, and in my own practice we use also laser therapy for pain release. If the patient had grade 2 stomatitis, symptomatic, but the patient can still eat in full modified diet, what is recommended is to stop the treatment. You wait that the grade 1 is observed, and then you reintroduce here the same dose. Why the same dose? Because probably when you reintroduce, you see less problems and you can go on with this dose. If, however, again you see relapse of a grade 2, then you have to go down to 5 milligram instead of 10 milligram. Concerning non-infectious pneumonitis, that is not a specific problem for everolimus, that is class effect for all mTOR inhibitors, and here the onset can be at any time. Most times it's between 2 and 6 months, but it can be very early within the first weeks and can also be observed later. Sometimes it is asymptomatic, you see just when you do your routine workup, and sometimes the patient has some symptoms. In the beginning, most times it is cough and dyspnea, and then other symptoms can appear, fever, fatigue, and in more severe cases, hypoxia and pleural effusion. Concerning the management, if the patient is asymptomatic, you have just to follow the patient. The patient had, of course, to be aware that if he developed or she developed symptoms, that the patients come back to the office, but you don't need to adapt the dose. If, however, the patient had symptoms, then you should stop the treatment, wait to recovery to grade 1, and then you can try to reintroduce, but at the 5 milligram dose. Sometimes the diagnosis is not so easy because this is an immunosuppressive agent, so you have to rule out infectious problems. You can also sometimes see some disease progression that can mimic non-infectious pneumonitis, so a multidisciplinary approach is useful. You can discuss with the pneumologist, with a specialist in infectious disease, If the patients have major symptoms, corticosteroids are highly effective, but of course, you should before have ruled out an infectious problem. So in conclusion, the Bolero 2 trial has shown that when you give this combination, exemestane with everolimus, you have a major impact in the progression-free survival. This is seen in all the subgroups evaluated, and in particular in patients who have just received the non-steroidal aromatase inhibitor in the adjuvant setting. The benefit in median progression-free survival improvement is important. Fewer deaths has been seen in the patient receiving the combined treatment, but we are still waiting for the mature overall survival data. And concerning the side effects, in general, they are manageable and they don't have a negative impact in the quality of life. So thank you very much for your attention.
Probably we are facing a new era because endocrine treatment for the last 30 years was more or less side effect-less treatment. Now we have very effective endocrine treatment, but we are facing new side effects, and that's something new. We have to adapt and get along with this.
The endoxifen is not working because genetically the metabolizer is system.
Because the drug is so cheap, is it worth it to make such testing to avoid that patients to be declared as induced resistance? No? Because sometimes we observe it's not working, but if we do the test, you observe with 5-FU and so on, from the first moment. And if we do such testing, we can avoid an unnecessary spending of money to patients losing their time, and we can offer the second-line treatment. Is it worth it to perform such testing?
We do not it routinely, and I don't think that it's done routinely somewhere, because you have these genetic problems, but you have also the drug interaction, and I think it's also a very complicated story. And for me, it is still a very confusing story. If I have heard the last discussion, I'm still not sure that we should really pay attention to this. So we give still tamoxifen to everyone without looking for something, and if it's progressive.
Are we talking about CYP2D6 testing? Is that the test you are relating to?
Yes.
Difficult discussion.
Yeah.
And I try to give an answer in Romanian, maybe. Am avut atâtea studii retrospective din care testul CYP2D6 a arătat că, într-adevăr, ar putea să joace un rol în predicția răspunsului la tamoxifen sau a rezistenței. Dar în același timp avem și trialuri negative și în atâta timp când avem și astea sunt tot retrospective. Deci ce ne trebuie, și asta spunem de 10 ani, ne trebuie trial prospectiv cu testul CYP2D6 prospectiv pentru a arăta că într-adevăr acestea sunt pacientele care sunt rezistente la tamoxifen. Basically, we are lacking prospective data on the CYP2D6 test and the clinical value of introducing this test into the clinical routine. I mean, retrospective studies, we have both. We have negative and we have positive trials. So at the moment, at least according to the guidelines I know, CYP2D6 is not recommended.
And in order to not to have acquired resistance, this strategy probably will give a longer response. Do you think it's worth it to try something like this?
We is looking to 5 years of extended adjuvant letrozole, either in a standard 5-year continuous way, or 9 months of treatment, 3 months interruption each year. So there you will see maybe a response to your question. It is 4,800 patients, so It's a large trial run by the IBCSG. I think the recruitment was stopped now 1.5 years ago. But we have still to wait for to see the results several years.
Thank you. Ok, nu mai văd alte întrebări, atunci mulțumim încă o dată. Thank you very much for the excellent presentation. Now you have to introduce me.